All right, so we're going live. 1, 2, 3, 4, 5, and go. We'll give ourselves a few minutes for people to join. All right. Okay. Well, thank you so much for joining us this evening. Today is July 17th, 2020. And today we're having the third in a series of Ghana Physicians and Surgeons Foundation weekly educational series. And today the topic for discussion is the neurological effects of COVID-19. And so I'm going to start by just giving you a brief overview of what GPSF is, and I will introduce the speakers, and we will be on the roll. Hopefully this will last for only an hour. Sometimes, depending on questions, we may go over just a little over an hour. And so my name is Dr. Bertha Sewa Ai. I'm an infectious disease doctor. I happen to be the moderator for this event, and I'm the vice president of GPSF. So what is GPSF? This is a Ghana Physicians and Surgeons Foundation. It was formed in 2002. And the mission and vision of the organization is to assist with educational efforts back at home, promote the public health of Ghana, and assist with graduate medical education. It is a 501(c) registered organization set up with the vision of one of the presidents of Ghana in conjunction with Professor Nyame, who was then the head of Department of Neurology. So it's kind of interesting that today we're talking about neurology, and also greatly assisted by Professor Ohene-Boakye, who is a neurosurgeon and based in Ghana right now. And so today we're talking about neurological effects of COVID-19, and I have two outstanding lecturers. Our first is the head of Department of Internal Medicine and Therapeutics at the University of Ghana. He's the head of the Internal Medicine Department. Dr. Patrick Adjei graduated from the University of Ghana Medical School in 1999. He has since completed a PhD in neurology at the Neurology Institute of the University of London. He has, and also a master's. He has recently given lectures on neurological effects of SARS-CoV-2 and the impact of COVID-19 on the brain and the CNS. He has stayed up to date, and he has a lot of clinical experience. He has a master's in neuroscience. I mean, he's good at what he does. And so I think he's best suited to share his experience with us tonight. And so thank you very much for joining us. The next person who would also be speaking and would help answer questions is Dr. Victor Owusu-Yaw. He's also a graduate of the University of Ghana Medical School. It looks like, from my estimation, he's about 12 years senior to Dr. Patrick Adjei. They went through the same institution. Dr. Victor Owusu-Yaw is the immediate past president of GPSF. He's currently an associate clinical professor of medicine at Edward Via College of Osteopathic Medicine and the Liberty University Osteopathic School of Medicine. He's a consultant neurologist at the Southern Virginia Hospitals in Danville, Virginia. And so without much ado, I would say a big thank you in advance to these outstanding physicians and listen to their pearls of wisdom. Thank you very much for joining us once again. And just housekeeping issues, they would finish giving their presentations. If you look down at the bottom of your screen or the top, depending on how you set up your Zoom, there's a Q&A session. You can type your questions over there and they will get answered, or you can also engage in a chat so we know that you are there. Give a shout out to us and we will give a shout out to you. So thank you very much for joining us. You're live on Facebook as well. Thank you. Dr. Adjei.
Thank you, Bertha, for inviting me to speak to this august community of physicians and surgeons. I thought I had no disclosures to make, but the only disclosure I have to make is I'm an early bird and I should be asleep by now.
And oh, wait, that's not, I have to mention that Dr. Adjei is giving us the lecture from Ghana, so it's 10 p.m.
The only disclosure I have to make is, and then right now. And then I was at the UCL Institute of Neurology, not the University of London. Okay. But that's okay. I think I'll start by letting us all watch this video. I think it's a very popular video. Just a few minutes.
Im Süden hat der Gegner Zossen genommen und stößt auf Stahnsdorf vor. Der Feind operiert jetzt am nördlichen Stadtrand zwischen Frohnau und Pankow. Und im Osten ist der Feind bis zur Linie Lichtenberg, Marsdorf, Karlshorst gelangt.
Mit dem Angriff Steiners wird das alles in Ordnung kommen.
Mein Führer, Steiner konnte nicht genügend Kräfte für einen Angriff massieren. Der Angriff Steiner ist nicht erfolgt.
Es bleiben im Raum Keitel, Jodel, Krebs und Butter.
Das war ein Befehl! Der Angriff Steiners war ein Befehl! Wer schickt Sie? Dass wir sagen, Sie seien Befehl zu widersetzen! Das Militär hat mich belogen! Jeder hat mich belogen, sogar die SS! Die gesamte Generalität ist nichts weiter als ein Haufen niederträchtiger, treuloser Feiglinge!
Mein Führer, ich kann nicht zulassen, dass die Soldaten, die für Sie verbringen...
Nicht Feiglinge! Verreiter, Versager!
Mein Führer, was Sie da sagen, ist ungeheuerlich.
Die Generalität ist der Geschmeiß des deutschen Volkes! Sie ist ohne Ehre! Sie nennen sich Generale, weil Sie Jahre auf Militärakademien zugebracht haben, nur um zu lernen, wie man Messer und Gabel hält! Jahrelang hat das Militär meine Aktionen nur behindert. Es hat mich gegen nur den Widerstand in den Weg gelegt. Ich hätte gut daran getan. Und darin alle höheren Offiziere liquidieren zu lassen, wie Stalin.
Ich war nie auf einer Akademie. Und doch habe ich allein auf mich gestellt. Ganz Europa erobert. Verräter. Von allem Anfang an bin ich so verraten und betrogen worden. Es wurde ein ungeheurer Verrat geübt am deutschen Volke. Aber alle diese Verräter werden bezahlen. Mit ihrem eigenen Blut werden sie bezahlen. Sie werden das saufen in ihrem eigenen Blut.
Oh boy, he's mad.
Just a few minutes.
Oh, sure. It's good. It's a good movie.
Es ist unmöglich, diesen Umständen. Es ist aus. Der Krieg ist verloren. Wenn Sie, meine Herren, glauben, dass ich deswegen Berlin verlasse, irren Sie sich gewaltig. Eher jage ich mir eine Kugel durch den Kopf. Tun Sie, was Sie wollen.
May Shako save us all.
That was a good one. We could watch it again.
We could. I'm sure the movie depicts a lot of things that have happened so far with this coronavirus pandemic. The neurologists were redeployed. The clinics were closed. Medical schools were shut down. Nobody wanted to use steroids against the virus.
Right.
Eventually, somewhere along the line, steroids have become the mainstay of treatment. for the virus and its effects. This lecture will be very brief, and I will talk mainly about pathobiology, which I'm sure everyone on the platform is quite aware. And then we'll go a little bit into how the brain becomes compromised, and then the brain effects and possible remedies that are available. The SARS-CoV-2 virus is coronavirus, just like its previous family, the MERS and SARS-CoV-1 infection. The current one is supposed to be a novel virus. We don't know much about it as compared to what SARS did. But when you read any standard text of medicine, particularly the book Cecil Textbook of Medicine, I'm going to tell you much about what happened during the SARS-CoV-1 outbreak and all the crazy things that happened. And after the epidemic, most of the touted treatments were not even found to be having enough evidence. I'm sure by the end of this pandemic, something similar will happen. It has the same structure like MERS and SARS. The infection that SARS-CoV-2 causes has a cycle that I think getting to know it will help us appreciate it much better. So everybody knows how it enters the cell, translates, transcribes, and leaves the cell. If you have a mature virion that leaves the cell through a vesicle, and then the virus is now presented to the antigen-presenting cells, which now start the body response to the viral infection. Excuse me. The main receptor that the virus has before it enters the cell are the AC2 receptors, which are all over the body: lungs, GI tract, heart, kidneys, nervous system, skeletal muscle. It is from this, it's quite obvious that the brain is not really secluded in the skull, like the video said, and the brain is not protected. If there are AC2 cells in the brain and we have the blood-brain barrier, we are expected to be protected, but one way or another, the brain becomes compromised. The antigen-presenting cells, everybody knows, are the macrophages, the microglia of the brain, and the dendritic cells also in the brain. So the microglia and dendritic cell play an active role in the viral pathogenesis in the brain. The host antigen precursors generate these host response mechanisms, which has now become very clear as the viral infection goes on, the so-called cytokine release syndromes. And I'm sure there are a lot of articles that talk about how the viral effect is not mainly direct viral effects, but rather indirect viral effects, which include the effect of inflammatory response to the viral protein, and the very severe forms that may occur due to macrophage activation syndrome or the hemophagocytic lymphohistiocytosis. And as we're all aware, this is usually associated with increased or very high serum ferritins when you evaluate such patients. And for our clinic, in our hospital, for instance, most of the very severely ill patients will have extremely high ferritins. And those with significant blood damage effects have very high ferritins, as well as those with brain involvement. So there's no doubt that the illness in SARS-CoV-2, the severe illness in SARS-CoV, is a mix of both the cytopathic effects, and the host immune and inflammatory response to the viral infection. And once we get this into this area of events, it's easier to somehow appreciate and do what we all best at doing, clinical care. Cytokine release. Only recently, there was one Ghanaian minister who was on radio saying that his infection with SARS-CoV-2 wasn't the cough that everybody had. He just had diarrhea. And it was a very intriguing thing on the radio. But it's just, if you appreciate how the virus functions, then many of the symptoms wouldn't be such an issue. It's multi-systemic. Diarrhea, tachycardias, hypotension, troponin elevation, acute kidney injuries, nausea, vomiting, myalgia, arthralgia, as well as what we are interested in, what happens to the brain. Headaches, confusion, hallucinations, delirium, aphasias, paresthesias, seizures. And once there's CNS involvement, there's also the tendency of future epilepsy. It's very difficult to distinguish between the CRS sepsis in very severe cases. And the signs of infection may mask the diagnosis and treatment of either. So I think it is very important that we always have this in the back of our mind whilst we approach the condition. It is postulated, we don't know it all, that nervous system involvement is either direct viral through via hematogenous spread of virus, or retrograde neuronal route through the olfactory bulb, or through indirect viral, which may be all the systemic effects combined: thrombotic, hemorrhagic, hypoxia, lung damage, cerebral hypoxia, blood-brain barrier compromise. Once cerebral hypoxia occurs, there's the compromise of the blood-brain barrier. And obviously, we can get the virus within the brain. So is the brain really protected? And is it fair to redeploy neurologists to general medicine, or leave us to do our work? I think it's a question that we all can answer. Headaches, confusion, hallucinations, delirium, aphasia, paresis, and seizures. Cytokine encephalopathy syndrome, impaired levels of consciousness, cerebrovascular events, ischemic strokes. We've seen a lot more of ischemic strokes as against hemorrhagic strokes as we speak in our facility. Encephalitis presentation. We've had a couple of presentations of encephalitis. Typically those patients that are extremely aggressive and irrational and extremely confused. And one that is still being debated, whether it was a pure SARS-CoV-2 encephalitis or cat rabies. It's one little boy, 9-year-old infant who had presented with encephalitic form of SARS-CoV-2 with evidence of PCR positive for SARS-CoV-2 and a history of a cat bite. Well, it's still being debated whether there's a cat bite, cat rabies as against SARS-CoV-2 encephalitis. Encephalopathy is quite common. All our 3 cases of retroviral infection had significant encephalopathy once we had them. Acute symptomatic seizures and potential epilepsy are cases we haven't seen some yet, but I'm sure most of us here may have come across some. Guillain-Barré syndrome and other peripheral nervous system syndromes are described as well. We had 1 case of Guillain-Barré and other PNS, paresthesias, but whether they were true paresthesias as against panics and anxiety at that time is something we are investigating. Muscle disease, quite common, myopathies and rhabdomyolysis. What is also quite common is anosmia. Anosmia is very common and can occur even in the absence of SARS-CoV-2, common colds, because of mucosal congestion of the conductive olfactory system, or due to involvement of the ACE2 receptors on the olfactory epithelium, which may become compromised during SARS-CoV-2 infections. Dysgeusia, loss of taste, quite significant. And we have all these neuropsychological effects, anxiety disorders, panic attacks, and currently, maybe I should leave that. Anxiety disorders and panic attacks, whether it's a true effect of the virus, host response, or part of the whole pandemic concept, and the anxieties and fears that comes with the various news and the massaging of figures and all the things that goes with it. It's something that we should look into very well. All these things have led to the concept of trying to classify neuro-COVID into stages, where very mild forms may be the stage 1, transient loss of taste and smell. Stage 2, where there's systemic inflammation involved with strokes. And then stage 3, neuro-COVID, where severe systemic inflammation with acute disseminated encephalomyelitis type of reactions, as well as acute hemorrhagic leukoencephalopathy kind of pictures. And this is a kind of difficulty that arises. And these patients might present to you with seizures, confusion, and encephalopathy. So when we look at it, most of the cases that most of us have come across, we've all come across stage 1, stage 2, and stage 3 strokes, as well as the encephalopathic cases. Very severe disease characterized by elevation of these disease severity markers will obviously have neurological features. And we should look out for all of it when we have these presentations. Edem, Guillain-Barré, strokes, new onset strokes, and all that. Another confounding factor here is most of these patients, especially in our setting here, have diabetes, hypertension. Hypertension has a relative risk for stroke of about 7, and that already puts them at risk of strokes already. And it is said that 2/3 of the Ghanaian population do have diabetes, hypertension. In a recent analysis of cases seen in the hospital, yet to be published anyway, you realize that having hypertension, diabetes increases your risk of SARS-CoV-2 complication, but it is not strictly associated with outcome, as in death or being discharged. So it's something that we can all look into. We cannot throw our patella hammers away. We still do need them, even though we may not use our stethoscope that much. Every case that you suspect has a neurological presentation needs a cautious neurological exam. You should check the reflexes, so keep your patella hammers. And all patients, I think,
I think Dr. Adjei's screen froze there for a minute, but I think he'll come back. Patrick, it looks like your screen froze very briefly. Were you, and you're on mute now?
Yeah, I'm back.
Okay, very good, very good.
The thing went up and came back. So I don't even know where my son is. Oh,
you were on the screen that said we shouldn't throw away our patellas, neurological exam, CSF, and
yeah. Let me try and get it done. Okay. So the neurological exam, we should do a lumbar puncture, CSF analysis, very important. And then I spoke about the EEG and then the brain imaging. Treatment generally supportive once you have these neurological conditions. The good thing is non-neurologists can help treat Guillain-Barré if they have it. Non-neurologists can help manage strokes if they find it. Like the encephalopathies, encephalitis, non-neurologists can help. But it's not a viral encephalitis. I mean, herpes simplex encephalitis. So we do not expect patients to be having a cyclovir for that matter. If you do your CSF analysis and you find features suggestive of ADEM, AHEL, I think you should go ahead and treat with steroids. Most importantly, those that have access to monoclonal antibodies or interleukin-6 receptor blockers. Tocilizumab does not cross the blood-brain barrier that easily and may not be very effective when you have neuro-COVID, either stage 3 or stage 2 neuro-COVID. When the patient has acute symptomatic seizures, we need intravenous anticonvulsants, benzodiazepines and phenobarbital. If you can have access to IV, levetiracetam, fair. Anxiolytics, sedative hypnotics in the encephalitic cases. I think today we have to get anxiolytic for one of the cases that have become quite encephalitic today, and I'm sure the response has been good. Notwithstanding, some will resolve on its own, particularly the GBS syndromes. The use of IVIG may still be controversial, but IVIG may not be available to all patients, and neuro-COVID may benefit more from steroids. Good. These are some of the images that you expect to see. So this is an MR image, and the bilateral hyperintensity, temporal lobe hyperintensity may mimic herpes simplex encephalitis, but in the setting of PCR positive for SARS-CoV-2, or in some situations, chest radiographs that support SARS-CoV-2, you might as well treat this as non-HSV encephalitis, but neuro-COVID stage 3. Bilateral thalamic hyperintensities, and this may be confused, except that we're confused with CJD, but CJD has a hockey stick appearance in the thalamus. But this is just bilateral thalamic hyperintensities, which is not so common. And this is straight away suspicious of COVID. This appears to be a video of one of the cases. Okay, this one had a big cerebellar infarction. Oh no, this was the cerebellar infarction. Let me just stop this one right here. Okay, so there we have the infarct with hemorrhagic conversion in there. And that is one of our cases, 86-year-old gentleman whom we treated as large infarctive stroke, SARS-CoV-2. And then this is another SARS-CoV-2 case with just a minor infarct in the basal ganglia, most likely in the thalamus as well. So that's another infarcted tissue there. Okay. So post-COVID neurological effects. Just Wednesday, one of my cases was who had been discharged more than 2 or 3 weeks ago, presented severe fatigue, negative for SARS-CoV-2 PCR, but has fatigue similar in its context to chronic fatigue syndrome. So this appears to be my last slide, but would we really think that we should relegate the neurologists back into general medicine? I think we do need to keep them, and we should be able to let them use their patellar hammers and what have you to continue the good works that the neurologists do. This is the last slide, and I always show this slide, which shows one of the greatest waterfalls in the world. It's a three-tier waterfall in Kintampo, in the middle of Ghana.
Oh, wow.
Those who like the sound of falling water, it's a very good form of therapy and creates very good relaxation. So if you ever go to ancient Rome, if you go to Rome and the city, the area of the ancient Rome, you have a lot of fountains, and these fountains provide relaxation. It's a good form of physical therapy. Thank you for listening to me.
Wow. You know, this is not an auditorium, but if it was, you would hear the whole audience standing up to give you a rousing standing ovation. This was excellent, excellent. From the video to the fact that you delivered a lot of material in 25 minutes, exactly 25 minutes. This was outstanding. Thank you very much. And that's a beautiful fall. It shows I haven't traveled the length and breadth of Ghana very much. I have to make a date to go and see this. I actually thought you were going to say New Zealand, or I couldn't believe this was in Ghana. So this was really, really good. This was good. Thank you so much, Prof. And so this was an outstanding lecture. I have like 7 questions for you, and I see questions in the audience already. We've been joined by 129 people. It's the largest we've had since we started this series. So I think people really wanted to listen to you and Dr. Owusu-Yaw. We have a few non-medical people. So I'm going to kindly ask you to explain ADEM. And then you used CJD. I think the medical people know what it is, but just for the benefit of non-medical people who are also, they've been sold to the fact that, oh, this is a flu, but from what you've described, SARS-CoV-2 is an evil disease. Last week we learned about its effects on the kidneys, and today you've broken down the effects on the central nervous system. So I would like you to explain those terms, and then we'll start digging into the questions.
Oh, okay. ADEM, it's a post-viral inflammatory demyelinating condition that affects the central nervous system particularly, and prevents as a acute to subacute neurological condition with significant morbidity and mortality. ADEM in its full term stands for acute disseminated encephalomyelitis. So it's both the brain that is inflamed as well as some parts of the spinal cord. And our experience in Ghana, it has some seasonal presentation really. And in this period where we are having the rainy season and that kind of thing, we tend to see a lot of ADEMs presenting in the clinics and the departments. So ADEM here means acute disseminated encephalomyelitis. There's significant demyelination. That's the nerve, the sheets surrounding the nerves acutely get demyelinated, which is not similar to the chronic demyelination that occurs in multiple sclerosis. This is just an acute, sudden presentation. And it responds so very well to steroids. Its severe form is AHEL, acute hemorrhagic leukoencephalopathy. And this is similar, very similar to ADEM, but carries higher mortality. And brain imaging, they show hemorrhagic areas really, as against the acute demyelination that you may see in ADEM. And right from the onset of SARS-CoV-2 and the presentation, the neurologists have always felt that the SARS-CoV-2 disease or the illness that occurs is somehow akin to the damage that occurs during these two conditions, ADEM and AHEL, or acute hemorrhagic leukoencephalopathy. CJD is Owusu-Yaw disease, is rapid onset dementia, not similar to the chronic dementia that occurs of Alzheimer's disease, the vascular dementias and all that, Pick's disease or frontotemporal dementias, or even the Parkinson's dementia syndromes, but it's just rapidly occurring dementia and has been associated with prion proteins and yeah, so that's what CJD is. And what was the last one?
It's okay. Well, the questions will come as we go, but I think I want. So, Professor Albert Takpalu, your senior man, said to tell you, great talk, Patrick. And Dr. Ida Vanderpoy has a question. She said, what happened to the child? Did he survive? If he didn't, was an autopsy done? And I think she's referring to the 9-year-old with a cat bite. And I'm sure you're saying this happened in Ghana, right?
Oh, yes. It's unfortunate. We lost the child and no autopsy was done.
Okay.
But he came quite aggressive.
And this was a 9-year-old.
9-year-old, very young child. And quite in the beginning of the heat of the SARS-CoV-2 pandemic in Ghana.
And he tested positive for SARS-CoV-2?
Yes.
Oh boy.
PCR positive.
Wow. That's serious. I see. So Dr. Joe Breu, I'm assuming is a physician, said, with the blood-brain barrier likely compromised in a neuro-COVID condition, does tocilizumab still have difficulty in getting to the brain?
It shouldn't, in the situation where the blood-brain barrier is compromised. But we are not assuming that the blood-brain barrier will be compromised throughout the whole brain. So it will be very difficult in that setting not to consider the use of steroids where it can easily penetrate other areas where the BBB is not compromised. So I think that's how we have to look at it. It's inflammation, but at the time, it's not the whole brain that is damaged. And it's not the whole area of the blood-brain barrier that is exposed. So that's the whole idea, concept. So theoretically, it shouldn't, but practically, it may be better off using the steroid as against the talk.
Okay.
And as we know that the neurons, when you spread them, they fill the tennis court, and so over 5 million neurons. So if a small portion may be compromised, and you really need to get to the whole area. So that's the whole concept. So, thank you.
All right, very well. Someone by the name of Vida, if I want to say it's in Ghana, I'll say obese, or if in the English, I'll say obese, but it says Vida says she's happy to be here. So hello to everybody. Eugene Kobla Dodoye said, Papa K, very good presentation you have there with the initial video. So I'm assuming you know Eugene. And Marian Opoku said she agrees. And Helen also says, big hand clap for good work done, Helen Boating. Someone said it was very insightful. We're waiting for more questions. And Joe Breu said, Kintampo waterfall will calm the SARS-CoV-2 panic attacks. This was great. Nicholas Obri said, very great talk, very informative, great presentation. There's a lot of hand claps for you, Patrick. Thank you very much. Kofi Apia said, good job from Senior Apim. So I'm assuming you know Dr. Kofi Apia. They said they loved the opening. The video was succinct. Thelma Alao Bila said, what is your take on low dose dexamethasone use? So if you can answer that.
Low dose dexamethasone use, I really don't have anything against it. And I think it should be used consistently. But what I have experienced really with the cases I have seen and managed, metalpred with confusion, in fact, neuro-COVID has been quite effective as against low-dose dexamethasone. And we've given 500 milligrams IV metalpred over 24 hours. And we've been good with the confusions that we get, the neuro-COVID stage 3.
Okay. And these classifications that you explained, neuro-COVID stages 1, 2, and 3, have they been well accepted by the neurology community, or they are things that are being proposed based on all the clinical presentations people are finding? Or was it one person who wrote a paper and said, hey, this is how I want to classify the neurological presentations of COVID?
Thank you, Bertha. But at the beginning, I said so many things will come out. But once the pandemic gets its hold on the human population, most of the things will come out to be clearer. It's a proposed classification, not something that's been widely accepted by the neurological community. Some people would prefer at least to use just the description of the condition. So if it's a stroke, you just describe it as a stroke. So when you look at the Queen Square group, where I was in UCL, they prefer to describe the neurological particular presentation. So if it's ADEM, they will describe ADEM. If it's anosmia, they just want to state it as it is. If it's a paraparesis, they want to describe it as it is. So Guillain-Barré, they want to describe Guillain-Barré and the response to IVIG. So it's a proposed classification, not anything written in stone. And it's neuro-COVID. There's a proposed classification, and if you really, it's better to take something that you can easily explain and then move on.
Okay, wonderful. So Foster Osei Opoku has a question, and I think we'll allow Dr. Victor to also give a US perspective, and then Dr. Adjei, you can also, he said, has plasmapheresis been used at all? He didn't classify his question, but I'm assuming, do any of these conditions respond to plasmapheresis?
You see, we haven't done it. I haven't done it. And I know Albert hasn't done it as well. And I'm sure Foster himself hasn't done it. But I don't know a group yet that's done plasmapheresis. But I need to check. But if you look at the pathophysiology and the presentation, if it's Guillain-Barré, plasmapheresis may be effective. And but there are a lot of studies pre-COVID that finds no real difference between plasmapheresis and IVIG if it's available. But it's just the cost of IVIG becomes prohibitive. But then the risk of infection becomes high in plasmapheresis. So in a highly infectious condition that you are dealing with, and you don't really understand how effective transmission is, or when transmission really stops, it may be prudent to hold on to procedures like plasmapheresis and that kind of thing in situations where you are confronted with Guillain-Barré. And if IVIG or steroids are available, maybe you go in for those ones. Thank you.
Wonderful. Dr. Owusu-Yaw, do you have any experience with using, or have you had to use plasmapheresis with any of the COVID presentations of CNS?
I guess plasmapheresis, like hemodialysis, involves putting in a permacath. Depending on which institution you are in, most small town hospitals would not have plasma exchange capability. So if you had a Guillain-Barré patient who had failed IgG, or you had a myasthenia patient who had failed IgG, and you wanted to do plasma exchange, most of those patients are transferred to more tertiary centers.
Okay.
Yeah. And I guess in most smaller hospitals too, the issue of dialysis patients, those who have COVID, are still dialyzed. So if they have the capability of doing plasma exchange, they would do it. But there have been situations where someone has multi-organ failure, they have an anoxic injury, they probably ultimately had brain death, but their creatinines were 14 and 16s, and the nephrologist would not touch those patients. Yeah.
Okay, wonderful. Thank you very much for your responses. Professor Adjei, there's a question here. First of all, there's a shout out from GNS. I think that's Ghana Neurological Society. I'm just guessing. Patrick Martin said, good presentation, senior. GNS is proud of you. And there are two questions. Helen Boating said, is the opening video available somewhere online? And so if you can share that. And then Amakwendu, who happens to be my older sister, she said, an excellent information for a layman like me. Good job, doctor. The presentation was excellent, and you had a nice supportive clip. So thank you for that feedback. And we've been joined by 138 people. I'm going to mention some names, but Prof, somebody has a question. Is the use of remdesivir beneficial? It's from Sylvester Danso.
I must say, maybe that one, I should pass it to Victor. I ain't use no remdesivir at all.
I don't even think it's available in Ghana right now. I mean, even in the US, you don't get it in every hospital.
I gather some people are trying to get some in the country, but I haven't used no remdesivir, so I don't know the effect at all.
So I guess for the most part, studies with Gilead's product are mainly geared to ICU patients on ventilators or on CPAP, BiPAP, or oxygen parameters deteriorating, that they want to prevent them ending on life support. Most of these patients, if they had neurological issues, they are already on those medications before a neurology consult is placed. I guess in my mind, I guess you can look at a primary COVID situation where somebody just has headache, somebody just has dizziness, somebody syncopized, they have taste and smell aberrations, and those symptoms are not severe enough to spend $3,000 on treatment.
Right, that's right, right. Okay, so Sylvester, you have your answer there. We've also been joined by Abigail Mensah, Abrefa Safuya, Adelaide Asante, Dr. Ikuya Siedu, Alex Tinkrai, Christian Deborah, Dominic Akatiba, Dr. Jifade, thank you for joining us, Estelamte, Felicia Ochri, and several others. I'll mention the names as we go along. And last week we had feedback. People said they want to interact versus just seeing the audience, the presenters. We did it this way to minimize the noise. So if you want to be seen, there's a way I can let you be visible. And so, Prof, I'm going to ask you to stop sharing your slides so people can see you better. And if you want us to unmute you and you want to say something, just type it in the chat room, because it will be a crowded screen if I let everybody be seen. Besides, when people know it's a webinar, somebody may be in their 90 pajamas, etc., and they don't want to be seen. So if you want to be seen, just type your name out there and let me know, and we'll have you speak directly with the presenters. And so while we're waiting for more questions, some of the things that have come out is that the CNS effects could be due to direct cytopathic effects on the brain, as well as immune and inflammatory effects of the virus. And Dr. Adjei, one of the things I was reading from the SARS outbreak back in 2003 was that there was actually a doctor in China who presented with a respiratory SARS. It took him a long time in the hospital. He was in the ICU, he was recovering. Then he developed this unusual neurological syndrome. He died in the end. And when they did autopsies, they found the viral particles, the actual RNA particles in his brain tissue. I've forgotten the reference, but it was an article that I read. What is your experience with finding viral particles in the brain post-mortem from all these presentations?
The issue is most of the cases that I presented did not die, and we've not had a chance to have postmortems on these any of these cases really. But as the virus, the pandemic persists and we go in deep, I'm sure we'll be able to get more information on these direct viral involvement of the brain. So I don't know whether Victor has any experience with that, but I haven't seen any yet.
I think most of the publications on pathology and postmortem, at least in the US, when New York was the epicenter, with morgues packed outside the hospital setting, then some clinicians, pathologists in neurology departments got to do postmortem exams. So most of these publications may involve 6 people, 12 people, 20 people, and some from China as well. In the real world, someone in the ICU gone through 2 weeks, 3 weeks of traumatic experience with cerebral edema, coma, being on medically induced coma, some with status epilepticus requiring anesthetic agents to break their status. By the time the patients die, the families have been traumatized enough that most of them wouldn't agree to, like, you've done MRIs and all that to prove brain pathology and swelling and diffusion abnormalities that we don't even discuss post-mortem, partly for fear of disseminating disease to other people who don't need to.
Right, right. Very good, very good. And in fact, I was reading a paper on autopsies done on COVID patients, and one of the things they mentioned in passing that the rate of autopsy requests in the US used to be 66%, and it has dropped to 33%. And the authors could not quite explain, just autopsy in general, requests for autopsy. They weren't sure if it's because physicians don't bring it up or whatever it was. So autopsies have gone down in general. And I think with COVID, I'm sure there's a risk to the pathologist, the risk of dissemination. So people don't request for it that much. I don't know if it's the same in Ghana, whether autopsies are done routinely or people even ask for it. And Dr. Adjei, the old man you presented who was 86 with hemorrhagic impact, this is in Ghana, right? It's not just a video from another country.
No. All my pictures are Ghanaian cases, really.
Right. So I'm almost thinking that sometimes you should share this with the public, because unfortunately there are people in Ghana who still believe that COVID is not real. Of course, even in the US, you have some people. There was a comedian who said it's not real, and I think 3 days later his son had it, so he changed his mind. So I think it will be important to share this with the Ghanaian community so people understand it's real and that they need to protect themselves. And so far as confusion is concerned, at the beginning of the outbreak, just personally, I was impressed by the number of old people who came into the hospital because their family members said, oh, you know, they're acting confused, or grandma is talking to herself, you know, sort of a slight encephalopathy. And at the beginning, they wouldn't get the test because the testing was very limited to cough and a fever. I don't know if Ghana has changed their, you know, criteria for testing to include neurological syndromes. Can you share that, or it's still you have to have the pure respiratory presentation?
Oh, not necessarily. I think okay, in my hospital, clinicians with a high index of suspicion based on the presentation, neurological, cardiorespiratory, unexplained gastrointestinal, would with also with a history of possible exposure, would test you, would request the test for COVID, really. So it's become more of a hospital-based, practice-based concept. And as in widespread requests for COVID tests in the setting of confusion becomes very difficult. It's not like a routine thing that is edged in the books for, or the standard treatment guideline for COVID that Ghana has.
Okay, and what about strokes? Because, you know, the New England Journal of Medicine published 5 people between the ages of 31 to 49. I believe the ages were 31, 35, 39, 41, and 49, who presented to a New York hospital with classic, you know, maybe middle cerebral artery stroke. They didn't have any respiratory symptoms. Only one of them, I believe, had diabetes or hypertension, but they were all positive, PCR positive for COVID. And this was at the height of the New York outbreak, COVID outbreak. And so I think those were some of the early reports of CNS presentation. So in Ghana right now, if somebody presented with a stroke, would they automatically get a COVID test because of this possibility, or is it an afterthought?
Oh, no, it's not, like I said, maybe I should repeat it again. It's not likely that you present with a stroke and then COVID will be one of the immediate tests. Yeah, it has to be the clinician or the consultant, the neurologist that sees and puts everything in together and decides this event, this no real risk factors, and the history that we have, let's evaluate for COVID. So it's not like it's automatic that you're going to get a COVID test once you come in with a stroke.
So would you say one of your
and we don't make it a policy that when you need a stroke, you need a COVID test to be admitted to a stroke unit, really.
Okay. So would you say one of your take-home messages for the 130-something physicians who are listening, that if somebody presents with a stroke, especially if you don't expect them to, they're young and they don't have any risk factors, that they should be thinking of getting a SARS-CoV-2 test?
Yes, in the setting environment, the current environment and the setting in which we are, if there is no real risk factor for stroke and stroke presentation, you might as well, in your evaluation, request a COVID test.
Okay.
At the end of the day, it's let's keep it here. It's COVID test is free unless you do it privately in Ghana.
Okay. All right, there's a Johnny Lordson on Facebook who says, Dr. Adjei made me develop interest in neurology during training in medical school in UGMS. I initially didn't like neuro at all. As always, he didn't disappoint. My question, is there any reported case of atypical psychotic presentation during or post-COVID-19? So do you remember Johnny Lordson at all, Dr. Adjei?
I'm sure I do. Now, I think there are two cases. I think today I talked about one of the cases that I said was encephalitic, was having an acute psychotic kind of behavior, and so it's been reported. And earlier on in the pandemic in Ghana, there were reports of acute psychotic behavior in SARS-CoV-2 positive patients on admission, really. So it's there, it's being described, but in the setting of an encephalitis, it's an acute psychosis. So it's maybe an encephalitis presentation as against psychiatry features or psychotic features. And maybe Dr. Victor may want to say something else, but we do have these acute psychotic episodes in some of these cases.
Right. Before Victor makes any input, I remember I was doing some radio interview and I mentioned that, patients with COVID can present with psychosis. One of the callers called in and said, you know what, this woman told us yesterday that the virus is airborne and now she's saying we can go mad. We're just going to give up and not do anything about this virus. So I thought that was interesting and funny. And there's someone here who says, Dr. Bongi Radar, she's an oncologist. Big hands clap to all of you panelists. Victor, do you have something to add to the psychosis questions?
I guess the British Psychiatric Association, they have reports online on psychosis and schizophreniform type symptoms in patients who were acutely COVID positive. Unlike a delirium where you may need antipsychotics and your symptoms resolve within a few days of being in the hospital, most of these psychiatric presentations, you may need longer term treatment with antipsychotics and tapering and weaning long after they've been discharged from the hospital. The same way as, I guess, we don't know always what causes schizophrenia. We always talk about autoimmune diseases, and COVID, like any other virus, affects hippocampus and areas in the brain where schizophreniform illnesses have been implicated. So it's not unusual. The longer this disease hangs on with us, every aspect of neurological diagnosis will be manifested in patients who have this disease. Looking at Guillain-Barré, for instance, the normal incidence may be 1 to 2 per 100,000 people. So in our community of 100,000, 150,000, I may see a patient a year or sometimes every other year. When there are millions, a few millions of COVID cases, you would expect maybe 30 GBS diagnosis if COVID was that strongly associated with it.
Right.
But it's just food for thought. Yeah.
Okay. All right. Wonderful. So I want to respect Dr. Adjei's time. It is 11 p.m. in Ghana, so he should be heading to bed, and he's done very well as all those who have with dedication joined us from Ghana. We really, really appreciate your patronage, and I hope you have learned a lot. Yvonne Echampon joined us. Dr. VPK Dankwa, the past treasurer of GPSF, joined us. Rita Afo, Rachel Ofer, Dr. Pearl Quote. Thank you for joining us. Patience Sakia, Patience Saka, Najama Globa. Many people joined us. We're really, really thankful. I hope you have learned a lot. And so this has been an excellent presentation. I want to thank Prof at this time. And oh, by the way, one question. Prof mentioned bilateral thalamic hyperintensities, and he said, oh, this must be COVID. So I wanted to ask, anytime you see bilateral thalamic hyperintensities, is that COVID for sure? Or is this something that is well recognized in the neurology world?
No, suspected.
Suspected, but is this something that's specific to coronavirus, or do you see it?
Oh, no, you can get it in other conditions.
You see it in other conditions. So what made you say, oh, this must be COVID?
Why it must be COVID is an uncommon presentation.
Okay, all right. I mean, this virus is bad. I think we can all agree that it's an evil virus, and we're trying to do the best with it. So I want to thank you all for joining us. This has been a presentation by the Ghana Physicians and Surgeons Foundation. Dr. Victor Owusu-Yaw is the immediate past president of GPSF, and Dr. Patrick Adjei joined us from Ghana. GPSF is not in Ghana, but we're one with them. It was formed to promote graduate medical education. So in the future, you would see that many of our programs would have Ghanaian-based physicians giving us lectures and US-based physicians. We want to foster that unity because we all went to some of the same medical schools. We just happen to be in different continents. And I always want to encourage people when we come for these conferences, if you live in the US, I want you to start thinking of doing something back at home, any type of healthcare projects. We're trying to organize ourselves so that we can make a difference back home. Sometimes it's the little things that make a big difference, and whatever you can do to help is fine. And if you're in the US here, we want to encourage you to join. Our website is GhanaPhysicians.org. Join us. We're a large group of physicians who like to have fun, hang out, study. And so if you want to hang out and socialize, raise your hand. I will let you join the panelist group, but I think out of respect, I would not be offended if Dr. Patrick Adjei has to sign up at this point. We want to thank him very much. And Dr. Victor Owusu-Yaw, both of them have had a full day. Dr. Owusu was running, I think you're on call in the ER, right? Or something like that. I caught him running and he said, you know, I just had to cut short what I was doing. So we're really, really appreciative of their time. Thank you very much for joining us this evening.
Thank you.
Thank you all.
Okay, I didn't see any more questions, just a lot of shout outs. So if you want to socialize, please raise your hand. We'll let you join. Everybody will see you and we'll have a little fun here. I see people hanging up and not raising their hand. Dr. Potaki from class of 97, Gadamoshi, Hafisatu Gadamoshi, thank you for joining us. Helen Boateng joined us. Isaac Arthur, Hannah Aite, Annie, thank you for joining us. Gina joined us. Francis Cobalt, Francis Arnansi, Fathia Karim, Eugene Tete, Asinu Agbeli, Emmanuel Atego, Enes Kujo, Emefadu Mevi, thank you. Emily Pipi, thank you for joining us. Diane Jan Obuobi joined us, Christian Adjei, Alfred Topa, Dr. Ikia Siedu, and Isaac Aqua and James Hayfron and Benjamin Egan had their hands up. I'm not sure if they had a question or not. Dr. Victor is still here. Dr. Ethel said, thank you very much, doctors. She'll be speaking with us in about 2 weeks on dental care. Eugene Dodoi said, with the presentation of delirium, psychosis is possible and must be looked for with a fluctuating consciousness. Thank you so much for that contribution. Margaret Niza said the information was crisp and informative. And Samdaki said, good job, Papa K. Let's see, nobody's asking any more questions. So I assume they had an awesome lecture. Seth Amega Sechuafia joined us. Samit Yako, Richard Doe, Prince Amon Kote, thank you for joining us. Patricia Akafari, thank you for joining. Oh, Omari Tinkran joined us. Omari is a good friend of mine. He's a pastor. I'm sure by the end of this year, everybody who joins this would have learned. It's going to be a mini medical school. And oh yes, Victor, your wife joined us, Dr. Nada Owusu. She kept quiet, but I think she was cheering you on the sidelines, Victor. Najama Glover, Muriel Ashimwe. Muriel is a pharmacy student. Muriel, thank you for joining us. Dr. Nicholas Alikwi joined us. Dr. Nicholas, let us know if you want to say something to someone, or if someone has something they want to share, please say so. Lanina joined us. Leila Alupeju joined us. Kwakai Papa Fio, Kate Fiado, John Gerald Adiboka, Jeremiah Akalainya, Baba, James Hayfron, and James Lawson. Okay, there are 2 messages. And in the absence of any further questions, okay. Emily Pipi said, please, will the recording of the session be made available? If so, it will be much appreciated. Yes, we will record it and put it on YouTube, but for your immediate enjoyment or pleasure, it was live on Facebook as well. So I would put the Facebook link on some of the WhatsApp pages. Actually, I'm going to copy it and put it here right now. And if you also let me know where I can find you, it'll be available. So it's going to be, oops, I just posted it to panelists, to everybody. Okay, so I'm posting it here. You can copy it and put it on your computer. Otherwise, I would share it around liberally, as I always do. Patrick Kamwating said, thank you for the presentations. Just a little bit of clarity. Ghana Neurological Society is the Ghana Neuroscience, I was just guessing, is the Ghana Neuroscience Society, of which both Dr. Adjei and Dr. Akpalu are members. Thank you very much for that clarification, Patrick. And I'm sure you admit only neurologists, but thank you very much. You can tell us how people can join. Delali also wanted access to the recording. I have sent it and I will share it around. Sylvester Danso said, thank you for the answer. Okay, there's one more question. Phyllis Aqua said, kudos to our honorable presenters. Excellent presentation. Do we get CME credits? Just curious. You know, I think we should. This is really, really good. I've sent a message to the Ghana Medical and Dental Council so that if you're in Ghana, you can get CME credit. I'm waiting on them. And we're looking into possibility of getting credit. GPSF normally gets its credit through the University of Alabama. We've sent a message to them. Just to break it down, it costs about $5,600 for an institution to be able to offer CME credits. And currently we pay a certain amount for our annual programs for them to give us CME credits. But since we're doing this every week, it almost makes sense that we should apply ourselves. So it's a good thing we're doing this frequently, because for you to apply to be a CME providing body, you need to prove that you're doing some educational activity frequently. And this is every week. So I think we should be able to qualify. We might have to find someone to give us a grant, an educational grant to be able to do this. But we're based on recommendation from Dr. Nicholas Alikwi, we're going to be giving certificates of participation. There's a way of finding out who attended. So if you either send me a message, make sure at least, you know, at least physicians have to have it to prove they've done this, but we'll try and send one to everybody who attended. So Phyllis, thank you very much for your question. Two new messages. Delali Fiagbe said, great show. Well, thank you. It was supposed to be great education, but great show too. Thank you. Amapoku said, thanks for the wonderful job and great presentation. There's one more question, which I think we've dismissed. Okay. I think on this note, Marian Opoku Ajakwa said, very insightful. Foster said, excellent presentation, my teacher. And Vida, if I crucified your last name, just forgive me. Okay, so I think at this point, Victor, you want to say some last words, or otherwise we'll end at this point. Thank you for, I know you're probably rushing to get back to your patients.
It's been a good learning experience as usual, and a good time to interact with colleagues and fellow Ghanaians and non-Ghanaians as well. So hopefully this disease doesn't stay with us forever and we don't have any long-term complications neurologically related to this disease either. So thank you all for attending, and thank you, Bertha, for all the hard work you do and making this happen.
Thank you. Okay, thank you. And Barbara Intro said, Victor, good seeing you. Kudos to all three. Bertha, I don't know how you do it. May the good Lord continue to strengthen you. Hey, yeah. The good Lord, may he continue to strengthen all of you as well. Anyway, thank you. And we will sign off at this point. It's been a wonderful experience. Dr. Adjei, thanks again. Good night. Hope to speak with you tomorrow. In Tree, we say, Adjei, Otis Akokobon, and then you know that I'm saying thank you, thank you, thank you. All right. Okay. Good night, everyone.